the summer. He's going to be discussing snake bite. The floor is yours, Osama.
Thank you, Dr. Saad, for the nice introduction. Good morning still, everyone. My name is Samuel Khulasi. I'm a 3-year emergency medicine resident. So in this talk, we are talking about something different and something that's a little bit scary for some of you, but you should not be scared of. Now, it's a snake bites. You can see in this first slide, I included a snake, which is really a cute one. This is the Wadi racer, which is not toxic. And you can see the skin is so smooth and the eyes is so rounded with the head. So don't be afraid. We'll get to the dangerous one later on. So what we are going to discuss today, we got through a clinical case, and from that case, we'll talk about the toxicity mechanisms and then the clinical manifestations of those patients, and we'll touch on mainly on the management. And also we'll give you some bears and pitfalls at the end. Now you have this 25-year-old woman. She felt that there is a sharp pain and she's stepping over something. And she went home, but later on that pain worsened and with a lot of swelling, and she decided to present it to you. Upon presentation, she was really crying with pain, but normally, with normal vitals. Here is her foot, and you can see there is some marks, maybe flank marks, a lot of swelling, a lot of ecchymosis. And with that history, the mind of you just ringing a bell that this is a snake bite. So how you can manage this patient, how you cannot miss a really dangerous consequences and complications. With this presentation, I hope that you will succeed on that. Now, when we are talking about snake bite, it's in general now, worldwide, it's very common. 5 million people are bitten each year, with deaths reaching 200,000 and also 400,000 amputations related to a snake bites. Now in Oman, we have 22 snake species. Only 9 of them are venomous. And well, one of the most common one is the saw-scaled species, which up to 90% of envenomation are due to this type. You can see if you compare it with the first one, it's a really ugly one with those epileptical eyes. And there are different types of snakes, venomous snakes in Oman, being also the other common one is the Omani carpet viper, the buff adder, which is present in the Sahara region, the Arabian cobra, and also the horned vipers. They are really scary, but you should not be. Now, when we are talking about venomous and non-venomous snakes, there are general ideas just to differentiate between them. You can see the venomous one has those triangular shaped head with a flanks and elliptical pupils. And also, if you look to the tail, and they have like single row subcaudal plates, comparing to the non-venomous snakes with a really rounded eyes, rounded head, no flanks, rounded pupils, and also they have that double row of the subcaudal plates. Now, there are different mechanisms of toxicity, neurotoxicity, myotoxins, and hemotoxins, and also locally toxins that will cause really blistering and necrosis. Now, when we talk about hematotoxic, which is the most common one here, this is the buff adder. Those videos and pictures are taken from Nizwa University in last visit, like 2 weeks back. So you can see those sharp flanks, those elliptical eyes. Those are really toxic. They are really ugly when they bite you. So they will present with an ecchymosis, a swelling that is twice the size, and it may be delayed to 3 to 4 hours, but still they are really toxic. Now they have also, if developed from local to systemic envenomation, they will present with coagulopathy. They may complicate to acute renal failure, reaching to shock, ARDS, and even cardiovascular collapse. The other types, the myotoxic here, this is the sea snake. It's venomous, but luckily no reported envenomation was reported in Oman. There is no available antivenom, and those snakes present with rhabdomyolysis, severe weakness, and also they carry also neurotoxicity, and they can present with weakness and respiratory failure or arrest. The other one, this is the most common one, but it's common when you know it, but it's not the common in number. This is the cobra. This is the Arabian cobra, and what you can elicit from this, they have the neurotoxin. They are really neurotoxin secreting as a venomation, and they may present just with mild, minimal swelling and inflammation at the beginning, but they can progress later on to a respiratory, even to respiratory arrest. Luckily, we have an antivenom. Now, what are the clues when you have a patient? What are the clues that this it could be a serious envenomation and a severe envenomation? Well, you have to know the type of the snake, if it's toxic or not. That will give you a clue, and also the progression of the swelling. Now you can see this patient at 20 hours. You can see just those flanks, but this progresses later on the complete swelling of that leg, and also the involvement of the far lymph nodes like the inguinal lymph nodes, and also some systemic signs and manifestations. With that, you have to look in the urine if there is anuria, oliguria, or a change in the color. Those might give you a clue that this patient have a serious and a severe envenomation. Now, whenever you suspect the patient that he has this envenomation, you have to go to dig deep in the history, what happened exactly, and where, and when, and also just take a history at previous history, if snake bite, if any antivenom was given at that time, and support the EBCs of those patients. And with that EBCs, if it's supported, also give TT, tetanus toxoid, and also manage the pain. Now they will present with a severe pain. Well, NSAIDs, there is you don't give NSAIDs in this. They have a risk of renal failure in this patient. Paracetamol will not work. Push that opioids to this patient. They deserve it. Antibiotic, if there is a signs of infection and really indicated, you can give it. Make sure you clean the wound, but cautiously, and mark that area. And then draw the labs. One most important labs are the whole blood clotting tests at 20 minutes. So you draw a blood in a plain tube, and you lift it, and after 20 minutes we'll check if that blood is clotted or not. And then the coagulation and CBC, and then the RFT. And I advise you also to bring the National Management Guideline of Poisoning, the page 228, and keep it at the bedside, and you can follow it. Now, the envenomation could be from no envenomation, maybe it's just dry bite, to a severe envenomation. Now, in a patient who have just no significant envenomation, you can see those small fang marks, which doesn't have a swelling or redness, and the patient is not in that much pain. The coagulation is normal. This clotting test at 20 minutes is normal. This is no significant inflammation. Do we discharge this patient? Well, obviously not. Those patients need an observation for at least 24 hours. So, and because we need to repeat the coagulation at 6 and 12 hours, and also to assess for the progression of the swelling and the severe, if there is any systemic manifestations. So if you repeat the three set at presentation 6 and 12 hours, and all are normal, and there is no systemic complications, they can be safely discharged. But if anything is deranged, you have to give the 4 vials of antivenom. So 4 vials in 100 to 200 ml, or you can run it over 30 to 60 minutes. And I stress on this: don't just wait for the coagulation. Observe the patient, like examine him or her like periodically, and see for any systemic manifestation and the swelling itself. Other patient, this patient have a clear also fang marks, but there is a swelling. there is pain, the coagulation is mildly deranged, there is no systemic collapse in those patients, and also plus or minus the whole blood tests at 20 minutes is also abnormal. You can see there is no clotting after 20 minutes. Those patients, you can consider admit them to the high, so they need a higher center. And those don't wait for, because there is something deranged right here. This one of them is enough. So you'll administer a 4 vials of the antivenom, and after administering that, will you repeat after 6 minutes, after 6 hours, and see if it is deranged. You repeat the same dose. If it is normal, you repeat it 12 and 18 and 24 hour. If everything is normal, you can also like de-escalate the high D to normal bed, and you can discharge. Severe inflammation, it's a really severe inflammation. You can locally, you can see the signs, black marks, and you can see the ecchymosis. The pain is extended from the foot upper, and also severe derangements in the coagulation. And also the test is the whole blood test is 20 minutes is negative, severe pain, and may or may not have circulatory collapse. In this severe inflammation, they need a high D, or you can consider an ICU admission, but those patients also need a higher dose of antivenom, from 5 to 10 vials you can administer to these patients. And the rest of algorithm is the same. You can observe for progression and repeat that coagulation periodically. Now, some pitfalls that happening, you can see this patient is presented with a lot of tourniquets around. Just remove all that. It's really not beneficial, but also harmful. Don't massage, and don't suck that venom, and don't do any physiotherapy and immobilize those patients. And also don't like routinely deliver that antivenom, because antivenom is drug and it has a risk of anaphylaxis. So don't administer this antivenom except if it is really indicated. And some of the tips for you, that you serially measure those swelling and ecchymosis and pain progression in those patients, because maybe in presentation there is no inflammation. After a few hours, it will be like a severe inflammation. Print that page from the national guideline. It will really guide you and help you to manage those patients. And also, when you send the coagulation, remember to trace it. Sometimes you send just the coagulation and wait for 2 or 3 hours, and it's severely deranged, and the labs is not reporting it. No, please go and trace those coagulations. And also, if the patient is weakness and paralysis, and there is significant history suggesting a snake bite, please don't hesitate to escalate this patient and intubate. These are 3 references that I recommend you also to go through. It will be available